While we're starting, maybe the two of you up there can comment. So, Fraser, if you're worried about instability, what's your go-to test? Are you doing supine, flexed extension, upright, CTA, or CT, FlexX, or oblique? What is your go-to first test you'll order?
So, how does this? All right. If you have the headache and the neurological symptoms and neurological findings, then the best test would be a flexion extension MRI, looking for that abnormal Bayesian axis interval, the abnormal clival axial angle, the presence of decreased CSF flow through the foramen magnum. So a flexion extension MRI would be the most useful single test.
And is that supine, where they're
well,
in the scanner?
Ideally, if you can get an upright flexion extension, it stresses the ligaments more, being in an upright position. But that's not available in most cities, in which case the supine with a pillow under the head for flexion or a pillow under the shoulders for extension would be helpful.
Any utility in plain x-rays? Old-fashioned?
Yeah, the x-rays are a lot more difficult to, they can be, I mean, I can look at the x-rays and see if there's something there that needs further imaging from an MRI, but it's a little bit, it can be subtle. And so, but as a last option, that would work. And even a flexion extension CT scan might be helpful.
No, thank you. Yang, any counterpoints or?
No, I mean, I would say x-rays these days, more seen as screening, as Dr. Henderson was mentioning. It's at my institution, we actually don't read the x-rays. The generalists are reading them, so they may not be in the hands of a neuroradiologist. That may be another issue. But yeah, flexion extension CT, it's some institutions, even at community hospitals, they may not be familiar. So you probably do need to go to a larger institution where the techs are more savvy and the faculty can help position and make sure that we have the right positioning, but very doable in the scanner, both for CT and MRI. And we often do get requests for that.
So for any of you, upright MRI is often a common question that comes up every year. In fact, our patients will say, well, my scan looks normal, but I have terrible symptoms. I know I have Chiari. Can you please order me an upright MRI? So how would you respond to that?
Yeah, I mean, I think there was a point in time where it was much more common. I was talking to even vendors recently. I don't think they're really, as popular now as they were at some point. A lot of it was started with lumbar imaging because the thought was with weight bearing on your spine, obviously there may be differences in how your nerves are compressed. So it started with, I believe, a lot of lumbar imaging that was done upright. But I can't remember the last time I saw an upright exam come to us as a comparison, or as even in the notes that I read from patients being referred outside. I don't know what your clinical experience has been in terms of how often those are ordered or performed these days. But
Fuchs or Henderson, anything comment?
Yeah, I'd just say that for the non-connective tissue disorder patient, a routine MRI is fine. But if you have a connective tissue disorder, or if you have alar ligament incompetence, if you're laying perfectly supine with your head resting, you may not pick up any disorder at all. You might miss it completely. So you have to kind of challenge or stress the ligaments to demonstrate their incompetence.
Yeah, so you may just have to look around for those scanners because they're not as easily found as they were, let's say, 5 to 10 years ago.
And Dr. Fuchs, when you look at a syrinx, it sometimes looks like there's 10 different syrinxes all hooked up together with the little haustra. Can you just comment on that? Many people ask, will the whole syrinx come down, or, is it all one cavity? How can you explain all those little ladders?
Yeah, in general, those are incomplete septations, and so it may not be that they're all lined up like holes in a Swiss cheese. They may be a hole here, hole there, that it's not a straight shot, but there's a series of incomplete walls there that usually do run the whole length. If there is a spinal cord like injury or something in that area where there's maybe an inflammatory response and a healing response, you may have more scar tissue there, which could impact the flow of CSF through all of that.
You can actually visualize that on the thinner section imaging with the flow. You can see the flow within some of those compartments and how they're not the same flow from one compartment to the next. You'll see swirling or sort of motion artifact, flow artifact, I should say, in one compartment that will be different from a further down compartment.
One more anatomic question, then we'll get on to marijuana, I promise. Hold on, David. So, and I know Dr. Keatings can't wait for this discussion. Tonsils, we often talk about the midline view, but some people say, oh, my left tonsil's down 8 millimeters, my right's down 4, but they still call this a Chiari, or is it really only on the midline MRI sagittal image? How do you deal with that if you have an asymmetric tonsillar descent in terms of how you would call it on a read? Yeah,
I mean, truly in the midline, if you're dead in the midline, sometimes you don't see a whole tonsil because of how the slice is through. So I don't necessarily I start in the midline, I draw the line, and then if the tonsil's not sitting in the midline, I'll move off midline, left or right. And again, if they're similar, I'll just report the one length and usually sometimes say like both sides are the same. If one is disparate from the other, then I'll report them separately, both in how they look in terms of roundedness or how peg-like it is, and give the two different measurements. So I think it depends on the anatomy in each particular patient. I would say most people probably have relatively symmetric tonsils. I don't know if that pans out at surgery. At least on imaging, most people have similar length tonsils in Chiari, but there are some like that one I showed, and that wasn't a case I really dug for. I just sort of put in Chiari in our search, and this is like the second case I came up with. I was like, perfect, this one's asymmetric, so I threw that one in there. So it does happen, and if that happens, I definitely report them bilaterally. I would think my colleagues would as well.
David, you showed a map of the U.S., and North Carolina looked like it was the illegal state. Here we are at Duke, so can you shed some light on what's wrong with our state? How can we get, why can't we get edibles, and what's going on with North Carolina and South Carolina?
I don't know. I'm not an expert in the regulatory environment, but I think North Carolina is a state that's illegal in both. Both of the Carolinas are. So I assume that you can't get medical or recreational in North Carolina, according to the latest that I have.
Yeah. And can you
it's a work in progress. It's changing all the time.
Can you highlight again at the end, you hinted at this association of use of marijuana and Alzheimer's. Was that correct?
Yeah, yes, that's correct. And I should have had a slide on that. We're involved in research at Drexel University on that subject. And they're finding that the stress function involved in late onset Alzheimer's disease is mitigated by marijuana. And so it affects symptoms significantly. Now, whether we're going to see that as they do some trials, we've yet to see. Those haven't started yet. This was just published recently, but I don't have it in front of me. I'll send it to you, and maybe Patrice can put it in your newsletter, because it was a fascinating result.
Yeah, interesting. Dr. Vez here yet by chance? We had funded through ASAP some of the work on this at Drexel. He's involved in a clinical study. So yeah.
Errol's wife, Elizabeth, is quite involved in that study and is one of the lead investigators. So he'll know what it's about.
Okay, questions from the audience? Sorry, I just want to get that off my chest, these questions.
Okay, thanks.
Thank you.
I was actually wondering on that note, when you say mitigated in Alzheimer's, do you mean like that it's affecting the epigenetics, or that it's alleviating? I think he's frozen. Can you?
David, did you hear that question?
I didn't hear the question.
Oh, regarding the Alzheimer's, I was just
Right.
curious on your test because one of the medications I get treated with is for Alzheimer's, but it's supposed to be neuroprotective. So when you said the use of cannabinoids were mitigating Alzheimer's, do you mean helpful, or just that it would show usage would show more likely to have symptoms or less?
It would lessen symptoms. It would mitigate the symptoms.
Okay.
Is what the initial work that Dr. Van Blocksteel did.
Okay. Thank you.
Next question. Ma'am, you want to?
Is there any study with, because you said women and their hormones and fluxing and all of that, and endometriosis coming out, and it's very hard to actually get any imaging with endometriosis. Is there any studies that is conducted to see if it's linked with endometriosis for women?
Was that directed to anyone in particular? Dr. Henderson?
Anyone who can answer.
Anything about hormonal change and endometriosis
Yeah.
link?
Endometriosis has been found in the brain and in the spine because it does travel. So, and it's it connects to the organs and everything. So,
Yeah.
you were saying about
Well,
women and
sure.
hormones and fluxing
Right.
and all of that. And is
Yeah.
that tied together at all? Is there any studies that are studying the female form?
Right. Yeah, I don't look at those studies in particular, but those of us who deal with all of these patients generally agree that many of the patients are super athletes when they're young, but when the hormones hit them more heavily in the second half of their adolescence or having children, that the symptoms come on much stronger. And we believe that this is due to the, hormonal changes in ligament strength. The ligaments get more stretchy, for instance, in pregnancy. So does that answer your question? Yeah, but I haven't seen an article on endometriosis per se, but it's not that I don't usually look at that literature. Yeah.
Not enough evidence, yeah. Question in the back?
Yes, I'm sorry. My name is Debbie. I'm sorry, we're going back to the cannabis, but the THC, are you saying that it's better to use the inhalated cannabis instead of the THC?
Inhalated, no. The THC is one of the active ingredients, and it's the intoxicating ingredient in cannabis. The inhalation gets it on board faster. And people misunderstand when they take an edible, they think they're not getting any effect at all. So they take another one and another one, and they start having problems because they're not waiting for the effect. That's what I was talking about.
It's just a longer effect, but the TLC is since it's the derivative, it's not a full derivative, I guess, of the cannabis, but it's the part that we want to eliminate pain, right?
Yeah, it's the most active in pain is the THC. The cannabinoids, the other side of the equation, is also helpful in mitigating other symptoms, nausea, for example. But the THC is most effective with the pain.
Okay. In Florida, you can go to a doctor, a cannabis doctor specifically, an MD, and you pay extra for that. It's not insurance. But once you have their approval, you're supposed to use only what they have, and you go into a regular smoke shop and say they tell you they're not allowed to sell you any of it. So it's kind of hard to decide where to go of the two places, and I don't know if you can give me advice on it, because I've found very few people and no standardization. I've gotten the wrong drops, different places and whatnot. You understand what I'm trying to say?
I do. That is the problem. There is no standardization. I talked about that in no standardization in dosage, no standardization in location. I'm not familiar with the laws in Florida, but if your doctor and you work together, you may be able to figure out what works for you by journaling and then replicate that
The
and
problem
over
has
again.
been so far is that of 3 or 4 doctors, every one of them have told me to use the stuff, but none of them know anything about it and aren't willing to discuss about it. So you want to think that you probably need to go to a specialist, but you don't want to block yourself out of the right to.
There are a lot of specialists in cannabis because it's only very recently that it's getting this amount of legality. And this Schedule 3 that I talked about in my presentation is brand new. It hasn't been implemented yet.
Yeah.
So until we get clinical trials, obviously the doctors who are present at this meeting with you can tell you that what they really want is clinical trials. But you can't do clinical trials with cannabis yet. There has been some done in Israel, as I mentioned, but not in the United States. So your best bet is to find, I showed you the example of the inhaled measured dosage put out by Mode, that device. If you Google that, you should be able to find where you can get that, and that could measure a dose. So it would be replicable between different forms of cannabis that you receive. But that's about the best you're going to do.
Thank you very much. And the second question I wanted to ask was for Dr. Henderson was, where can you go to have the cranial instability testing done?
Well,
Who's doing it and who's up in it? Because there's a lot of doctors that, you go to them and
Yeah, well,
you're
I
not
know
getting
around,
anywhere.
Yeah, around the District of Columbia, there are 5 different places, and I think there's maybe one in Houston and one in New York. They're scattered around the country. I wish they were in more cities, but they're not.
So if we want to come to you, how do we do it?
But when you speak to me afterwards, I'll tell
Okay.
you. But, yeah.
Other questions?
Yeah, I was just curious with a patient in the context of a complicated medical picture, specifically neurologically. How do you differentiate between symptoms that can be attributed to craniocervical instability and maybe some other of a myriad of issues? And then kind of on that, if you have a connective tissue disorder like Ehlers-Danlos, which I do, is there any downside to not following up on that craniocervical instability? I believe you referenced the kind of wearing out of ligaments and potential stroke risk and whatnot. So I'm just trying to understand that
Yeah,
more
I mean,
clearly.
if having surgery is sort of your last resort, and when you can't deal with the pain and the disability anymore, then you need to look into the option of surgery, whether you're a reasonable candidate. But if you're hemming and hawing about it, then you're not suffering enough to be a candidate for the surgery. As far as when we look at craniocervical instability, we're ruling out in our minds about 30 or 40 other conditions. So, a patient looking at the symptoms could say, "Oh, that's what I've got," but it could easily be multiple sclerosis or primary lateral sclerosis or heavy metal intoxication. I mean, there's so many things that can have similar like symptoms. But he mentioned that we've just come out with a 80-chapter book on every symptom of Ehlers-Danlos syndrome, written by experts around the world, and it'll give you direction on where to go, what to do. It's called Symptomatic, the Medical Practitioner's Guide to Ehlers-Danlos Syndrome.
Yes.
I'm not really sure when it's appropriate to ask this question, but I met another lady that has idiopathic Syringomyelia, and I've heard a lot of you guys talking about the tether cord or traumatic injury or spinal bifida causing a syrinx. But what about when you have idiopathic? There's no known cause. Is there any studies? In our case, we have a familial idiopathic syrinx that's debilitating. So is there any idiopathic help, causes, or treatment?
Fuchs, do you want?
Well, I think with idiopathic, I mean, it basically means we don't know what caused it. So that first of all, you kind of have to do all the things that we talked about, and try to rule out Chiari, tethered cord, tumors, et cetera, all these other conditions. And you're sort of left with, you have a syrinx, but you don't know what caused it, so it's idiopathic. And then oftentimes it depends on what the symptoms are. At first, we may be watching that, see do the symptoms progress, does the lesion progress on MRI, in which case you look at then treating it surgically. And the thing is, with these other forms of tethered cord, if Chiari is, or syrinx, if Chiari is causing your syrinx, if tethered cord is causing the syrinx, you're going to operate on that underlying condition to try to treat it. If you do not have an underlying condition there, if you don't see instability, you don't see anything else there, then that's when you would look at perhaps shunting that syrinx, draining it, either shunting it syrinx to subarachnoid space. You heard from Dr. Levy also syrinx peritoneal or syrinx pleural. When he was talking about patients that have had like spinal cord injuries, there's a lot of scar tissue around the spinal cord. They're just doing a syrinx subarachnoid shunt really probably won't work. The CSF flow isn't, or you need to get the CSF drained to another spot, and that's either the abdomen or the chest.
If you accept, how long do you follow these syrinxes? So say they're idiopathic, minimal symptoms, some back pain, but normal exam in a child versus young adult, older adult. What is your general scheme of how long do you think it's worth MRIing these patients?
Well, part of it depends on how old they are. The younger kids, if we see them that they can't really communicate to us well what's going on, unless there's a significant neurologic deficit, you don't have a lot to follow. And so I'll image them more. I think as they get a little older and can tell us more what they're feeling, you have a better neurologic exam in terms of some of the sensory findings and all, and look at how they're doing developmentally, back off. And after a few years, typically, if we've got a good exam to follow, I'll just say, unless there's a neurologic change, I won't keep doing MRI after MRI.
Yang, have you seen anything evolve in your experience?
Yeah, I mean, there are times when we had a recent case, it's actually Dr. Frim's patient that had, I think it was like a teen, not a really young child, but also not a full adult yet, who had multiple MRIs. I think we were going on 10 to 12 years. We've each read at least one. And the syrinx, this is where I referred to the tidbit of sort of going back many exams to compare. So the last year, 2 years, 3 years, there wasn't much change. But in this particular patient, if you go way back, of course, there is a change. How clinically significant is that change is not up to us. That's obviously up to the clinicians to decide if that's even relevant clinically. But visually on imaging, it can change slowly over a lot of years. But I think that's ultimately a clinical decision of how long to follow.
That's such an important point. I mean, if to remember when you're being evaluated, particularly for a child, we see this with brain tumors as well. It's always compared to the last scan. Mm-hmm. Always go back to the original diagnostic scan, way back to the beginning. Yeah. It's incredibly instructive to see where did this all start. And if you don't have that timeline, we really want to get those pictures. It's no different in Chiari, syrinx, tethered, you just want to get that time constant, which is often rare, Okay, all right. Well, we're almost out of time, I guess. Yes.
I came for some answers, and I want to know if anybody else had a syrinx caused by an arachnoid cyst pressing up against the spine. Is this pretty normal or abnormal? And I had to have the arachnoid cyst excised, but I have been living, and the syrinx shrank, so I'm walking and doing everything below the thoracic level. But I still live with pretty bad pain. I'm just wondering if anybody else had experienced this. And if you guys have heard of or know of this, if this is abnormal, or is it abnormal or normal? Or
an arachnoid cyst is another thing that will interfere with the flow of spinal fluid along the spinal cord. And so if you have a significant arachnoid cyst with cord compression, you'll also get injury to the spinal cord. So a couple of those factors are going to factor into the possibility of developing a syrinx. Yes.
But you bring up a really important issue that, is that it was highlighted earlier this morning or earlier today that the syrinx size doesn't necessarily correlate too well with symptoms. And that's also true after surgery. Syrinx looks good, but obviously you still have ongoing symptoms, and spinal cord gets really stressed, then it looks better on imaging, but you're still having ongoing concerns because the spinal cord doesn't heal that well. That's a real problem, and that you can look at the films, say you're fine, but obviously there are ongoing issues that we can't control, or we have to rely on other adjuvant things we've talked about here today to manage. So that's a really important point in general. So thanks for bringing that up. Yeah.
I have spina bifida and Arnold Chiari as well, and I was wondering if they're doing any more research on Chiari too.
The Fuchs runs our spina bifida clinic. Any comment?
I mean, there's a number of studies, there's a number of registries. We're looking at trying to get everybody, again, the more data you have, the more useful it is. So getting some of these spina bifida registries in so that we can really catalog patients and say, what is typical course for some of these patients? What do we see as complications? The timeline for some of these, and just gathering that data is a huge undertaking, and hopefully in the years to come will really inform our decision making for clinical care way beyond what we can do today.
There's a lot of interest for sure. Stem cells we talked about, cord blood. People have gone outside the United States because it's not approved here. And there are clinical trials that are ongoing, cellular-based therapy. There are things that we talk about for any kind of spinal cord-related issue, but not ready for prime time, particularly in children because of the increased risk. Stem cells, there's always this risk of a stem cell turning into a cancer.
Yeah.
And you can imagine with a child, that's a huge implication of putting these cells in your body. So there's a risk benefit with everything we do. We have to be very, very careful. That's why the FDA is obviously watching this area very closely in part of clinical trials.
At one point there, the pluripotential stem cells can become neoplastic, but other stem cells don't.
Yeah.
Question? Yeah.
Question for Dr. Henderson. I was just curious your thoughts on, for the connective tissue disorders, of a patient seeking a rheumatologist for autoimmune and for those connective, or would the first step be the flexion MRI, like you mentioned, for the disorders maybe aside from instability and EDS?
Yeah, rheumatologists make a lot of the diagnoses, of Ehlers-Danlos syndrome, so that's a very reasonable person to go to. And you do have to differentiate the pain of the joints of EDS from other rheumatological conditions. So I think that's a very reasonable way to go, and rule out the medical things first.
Last question? Yes.
It's already on.
We have adopted, my husband and I, several children that have spina bifida, and we've been foster parents to a few. So altogether, I've cared for 9 kids that had spina bifida, and I've lost several because of the Chiari. So in March, Lloyd was with me shopping, and I sent him to get something down the aisle, and he didn't come back. And then they came and got me and said he had a seizure and fell out of his chair. And so they called an ambulance. We went to the hospital. He had a big cut on his forehead, and he really slammed the floor. He didn't just roll out of his chair. And now one doctor thinks it was because of the Chiari. It was something that happened because of that. The neurologist thinks it had to do with a seizure he's never had seizures. What would be your opinion on that?
That's kind of hard to tell. There's a lot of different factors that could be there. I mean, there are certainly with the Chiari, there are abnormalities in the brain itself, so there could be a more potential for seizures as well. That with something going on, some either physiologic change, other stress that might have lowered a seizure threshold there. And then depending on what happens with that event, there could be changes in circulation. You could have pressure effects that then affected the Chiari as well. There's a number of different places that there could be a significant problem with that. It's hard to put that just together with that little bit of data.
Thank you.
Great. Thank you.
And somebody that's had syringomyelia for, over 20 years, is there research out there that leads to degradation of bone and other parts of the body?
I don't think so.
I certainly don't remember seeing anything like that.
I have not seen anything like that either.
I mean, outside the spinal cord.
Yes.
Yeah, I haven't heard anything like that.
Bilateral hip replacement and both shoulder joints. So, yeah.
Not that
Okay,
I know
thank
of.
you.
Not as a,
Well, if a syrinx is in the neck and causes problems with the motor neurons to the shoulder, it can cause weakness of the shoulder and eventual weakness of the shoulder girdle, and then might lead to a shoulder replacement. And similarly, if there's a syrinx in the lower part of the spinal cord, it could lead to weakness of the muscles that protect the hip joint. That can lead to weakening there and possibly eventual joint replacement.
as secondary effects.
Yeah.
Well,
Well, great discussion. Thank you to our panelists for bringing this over.